In recent years, we've learned that a person's zip code is more predictive than their genetic code when it comes to your health. What does that mean? That means that if you happen to live in a poor urban neighborhood where the only place where you can shop is either a dollar store or one of the bodegas, you may not have access to high quality, nutritious foods that we expect you to have if you have a kidney-friendly diet. You may not be in a neighborhood where you feel safe to walk. And so being sedentary leads to obesity, which leads to diabetes, which leads to high blood pressure, which leads to chronic kidney disease.
If you have poor transportation in your area and you don't have a car, it's very difficult to get to the doctor. And a lot of times you may not even have the money to pay for parking to go see a physician. You may lack the money to pay for medications. And right now, the medications that we have that can really help prevent kidney failure have very high copays. So it's very expensive for an individual to try to prevent kidney disease, especially if you don't have transportation, you don't have access to nutritional foods. And that's one of the major reasons why there's this huge discrepancy in kidney disease prevalence between people who are poor and people who are not poor.
The average patient who's going for chronic kidney disease treatment, or dialysis specifically, will have to go 3 times a week to a dialysis center. Now, getting there, especially in rural America, isn't easy. It's hard enough for someone who has means. Now, if you don't have your own car, it's very hard. And there are going to be times where the patient can't make it for one or more reasons, and they end up sicker and they end up in the hospital. All of these things add up over time. A lot of what happens in American medicine is a one-size-fits-all approach. And when we start to look beyond the design of the system for the average person to those edge cases who are not your average white male 40-year-old person, the disease looks very different in those people. And disease progresses very differently in those people. And those patients with chronic kidney disease and end-stage renal disease are the ones who are most vulnerable. They're the older, poor, with fewest resources, with the fewest social supports, the hardest to treat because it's hard for them to stay adherent, hardest for them to get to clinical visits, and so they end up costing a lot more to our taxpayers. The opportunity to not look at them through one lens, the one-size-fits-all, is why we're here today.
How do you educate somebody on doing something different when somebody's done something the same way for years and years and years? And like, my mom told me to do it this way, my grandpa does it this way, my great-great-grandpa does it this way. And now we're saying, like, don't do it that way, do it this way.
One of the major issues of kidney disease regarding government support compared to other diseases has to do with research investment. Historically, there's been very poor research investment in figuring out ways to prevent kidney disease or early detection or treatment of kidney disease. So, for example, we spend probably around $400 per patient with heart disease for research. We spend about over $1,000 per patient with HIV. We spend about $17 per patient with kidney disease on research investment. One of the reasons why we may be spending much less in kidney disease, in my opinion, is because of the fact it does disproportionately affect non-white people who are disenfranchised. So they're not speaking up. They're not asking for more research investment, right? We lack a strong advocacy voice in Congress. Whereas heart disease, has the American Heart Association, very powerful voice, right? You have the American Cancer Society. You have all of these very strong groups that are at the table advocating. But our population, they lack a voice. But we're trying to change that.
Sadly, there is no silver bullet. To understand the context of a person's lives with the tools we have at hand, it's very complex. You can't just write a check and make it go away. There's no one person who can actually change the situation. We as a society need to determine that this is a priority and bring all of the resources necessary together in the right ways to meet people where they are.
So we could provide more education to increase the awareness of kidney health, because it's not difficult to measure kidney disease, just a simple blood and urine test. So if we get people to be more aware of the importance so that when they go to their doctor, they could say, how are my kidneys? Have you tested my kidneys? Do I need a medication for my kidneys? And we could certainly refer people to see a dietitian to try to get them to change their diet or improve their diet, exercise more. But we need to really focus on prevention of kidney disease and promotion of kidney health in high-risk groups. They deserve good health care just like everybody else.
We have the tools available. We have the knowledge available. We just need to decide as a society that this is important enough and help people where they are. It's not on them, it's on us. And if we can get together and address the social determinants of health, reduce disparities, and care for people where they are in their own context, we can make a fundamental difference and change the lives of millions.